Okay, junctional rhythms. Rhythms starting from the AV node itself. So let's talk about this just to kind of clarify a few points because I know this can be a difficult concept to grasp sometimes. So we'll do a real quick, simplistic drawing of the heart. So you've got your atria and your ventricles. And so you've got your SA node up here, or your sinus node, whatever you'd like to call it. And then right here is your AV node. And so the AV node itself is just that. The section of it here that crosses into the ventricles, that's what is included when we talk about AV junction. So just to give you a slightly better picture of what I'm talking about. And no, this is not to scale or by any means perfect, but hopefully it'll help you get the idea. So this section right here, this upper part, is the AV node. And then this next section through here is your bundle of His. And so that entire part there is your AV junction. And that's what we're talking about, is those different parts. The remainder of this from here to here, that's your bundle branches. And that's a whole separate thing. So the rhythms that we'll talk about with this section arise from one of these two areas, the AV node, bundle of His, essentially the AV junction. For basic arrhythmia folks, we're going to talk about supraventricular tachycardias. For the advanced arrhythmias, we're going to go into true junctional rhythms themselves. Electrical flow with junctional arrhythmias follows this idea, essentially, that the AV node and that bundle of His are that initiation point for the impulse, so right here. What happens is that electrical impulse flows backwards and forwards simultaneously. So in the idea of doing the ripples in a pond, that electricity is going to travel all directions at once. In this case, it's just forward and backward. It's going to use your usual stuff, so cell to cell, your internodal pathways, and your bundle branches. What makes this kind of cool is a few different things. When it travels down the bundle branches, it'll produce a normal QRS. But in the atria, what happens is because it's traveling backwards, also known as retrograde, that will cause your P waves to actually be backwards of what they're supposed to be. So instead of being like this, your P wave will actually be upside down because it's occurring reverse of what it normally should. And then the other important part is that it's happening simultaneously. Just like in a pond, if you create those ripples, they travel equally in all directions. And so in this case, that P wave and that QRS are also going to do the same thing. So let's take a closer look at that. And here are the examples of how that inverted P wave might appear depending on the timing. So two important things that I want to point out to you is that it will always be inverted. And when it appears completely depends on the timing. And what do I mean by that? Well, let's just simply say that based on the timing, it will either be before the QRS, and that's what I mean by ventricles. It'll be hidden or during, the QRS, or a third option is it can actually appear after the QRS has finished its sequence. And that's really cool for a lot of different reasons. It means that you have to look closely. You have to hunt for these inverted ones, and if they don't appear, you may actually have to find yourself looking after the QRS to see if you can locate them there. One of the bigger rules that you can really take from here is that if there's an inverted P wave, it's very likely that it's junctional. So it almost always means that you've got a junctional rhythm. And more importantly, if you have a normal QRS and then no P wave, you're probably also dealing with a junctional rhythm. You just have to go through and prove it. And so that's what we'll go through next. Beats that arise from the AV junction have an inverted P wave when monitored through lead 2 because A, you cannot see the P wave in junctional beats. The impulse travels retrograde through the atria, causing the P wave to be inverted. That sounds familiar. Junctional beats are ectopic. That's reason enough. That is definitely not the answer. The impulse travels through the bundle branches within the ventricles normally, then wraps through the atria and travels backwards. That's incorrect as well, for sure. So after walking through those, yeah, B is your answer. The impulse travels retrograde through the atria, causing the P wave to be inverted because it's traveling away from lead 2. Starting quite simply, mechanism for a premature junctional complex. And the ideas are based upon what we've already talked about already. Like all premature beats, it is based off of an irritable focus. In this case, it happens to be in the AV junction. What happens is two different things. It obviously is firing prematurely. It only produces a single ectopic beat. This is not an organized rhythm. The QRS will be normal. Nothing funky about that. It's not an entire rhythm, just a single ectopic beat, and you have that retrograde conduction, or backwards. So you're going to be looking for the inverted P. Rules for your premature junctional complex, PJC. The regularity and rate, well, rate depends on the underlying rhythm. You're going to have an irregular rhythm because there's an ectopic beat present, right? You can have a pattern, though. That's entirely possible. You'll just have to look for it. The P wave, it will be inverted, and it's just like we said before. It's going to be before, during, or after the QRS complex. If you have a P wave, this is the next big important thing on any kind of junctional rhythm. If there is a P wave before the QRS, it will have a PRI less than 12 seconds, and that's absolutely key. If you have an inverted P wave, but that entire PRI is not shorter than this, then that means it's not actually a junctional complex. How does this happen? Well, basically because it's originating in the AV node. I'll actually go back a second here. Because it's originating here at the AV node, depending on its location, which can be anywhere along this track, it might actually bypass the delay. And that's what causes that PRI to be short. And of course, your QRS will be less than 12 seconds. Or sorry, less than 0.12 seconds. All right, take a look at this like we would any other strip. It is 6 seconds long. You've got your bits right here. And we've got 1, 2, 6 beats. And so 6 beats, 6 times 10. 60 for your heart rate overall. It is irregular. I have, let's see, number 5 appears to be an ectopic beat. And there is no pattern. Going on, let's see if we can figure out about our P waves. They all appear to be in pretty good shape. We'll ignore the ectopic for now, and so our native P waves are upright and uniform. They have a regular pattern to them as well. I have 1 P per QRS. Now if we look at our ectopic, there is no P wave. So if you look right here where we'd expect to find it, there's nothing in place. So that's good to note, and we'll come back to that. As for the PRI with our native, we're going to measure that out to be, we'll say it starts about right here and here. We'll call that a 4. So that is normal. And for our ectopic, no P equals no QRS. Sorry, not QRS. No PRI. All right, finally our QRSs, they are uniform. And they have the R pattern. The ectopic is actually identical. So that just leaves us with a really quick measurement, and we'll go ahead and take this one here and say that we are about 2 boxes. So 2 times 0.04 equals 0.08. Now you may ask me the question, why did you go with this location here as the end of your QRS and not way down here? Well, because there's some sloping involved, it really does make it a bit more challenging to decide when your QRS ends and when your ST segment begins. Fortunately with this one, it's really only a matter of about a block or so, so it really doesn't create a bundled branch pattern per se. But what I will say is this: if you look at beat number 1, you can see how there's a really sharp demarcation between it. So if I started here, this is where my R wave definitely ends at this location. And then it kind of slopes down after that. The angle has changed. That's the J point. And so I use that to determine where it ends at. That's the reason why I went with that. If you check a different one, like over here on number 6, you can see it a lot clearer as well, from about here to here. And again, that's about 2 small boxes. Ultimately, what are we left with? Well, it's essentially sinus rhythm with a premature beat. So we were early. It doesn't have a P wave, but the QRS is essentially normal. And so at that point, the P wave is probably within the QRS somewhere, and that's why we can't see it. And so we're left with sinus rhythm, PJC. Why are premature junctional contractions important? Why do we pay attention to PJCs? Well, they're never normal. They're not to be expected. In situations where you have an AV block that could potentially be occurring sometime in the future, that can be the case, so they may precede an AV block. Rarely do they actually cause any symptoms. It's just more of a, if you're going to recognize these, you need to be able to identify them, and so that is what a PJC is. Not much else to them than that. Oh, irritation is the other one. So if there is, again, anything that might cause irritation to those cells, in particular, decreased oxygenation, so heart attack, of course, or just coronary artery disease, something along that line, could easily be one of the triggers for this. All right, moving on from a single ectopic beat to an organized rhythm that starts in the AV junction. So pacemaker, of course, is going to be the AV node and just the junction overall. It has an inherent rate of 40 to 60 beats per minute. So when does this occur? Well, two main scenarios. When a higher pacemaker fails, so that would be like the SA node. If that should drop out for some reason, that's one of the biggest type scenarios. Or in a scenario of irritation, where the AV junction becomes excited and winds up beating faster than the SA node, and in those situations it can actually take over. Ultimately, AV node and junction are responsible for that heartbeat. We're still using that retrograde conduction, going backwards. And so that's why you will have the inverted P wave. But you will have normal conduction through the ventricles. And so what are the rules for junctional rhythms? Fairly straightforward. In fact, the major dividing point between each of these is based on the rate themselves. So the inherent rate of the AV junction is between 40 and 60. And so if you have a junctional rhythm and it's going in that rate range, we're going to call that junctional escape. The idea with the junctional escape is that higher pacemaker has failed. The sinus node has quit for some reason or is being blocked, and so the junction takes over. If the rate is going faster than that, so if it's going in that 60 to 100 range, we now call that accelerated junctional. Sorry, I'm going to put the abbreviations next to them. In accelerated junctional, this is a situation where an irritable focus has probably occurred in the AV junction, and it speeds up and it actually overrides control. And then finally, following the same rules as sinus rhythm or atrial rhythms, if it goes faster than 100, we call it tachycardia. So sinus tach, atrial tach, junctional tachycardia. So when it goes faster than 100, usually tops out around 180, we call that junctional tachycardia, or JT. That's a poor looking J. There we go. Regularity. It's going to be super regular. Junctional rhythms are some of the more trustworthy regular rhythms you'll come across. The P wave, as we talked about earlier, it's going to be inverted for sure if you can see it, because it can fall before or after the QRS complex, or even be hidden or during the QRS. So keep all that in mind. If you can see the P wave before the QRS, the PRI will be less than 0.12. Have to keep that in mind. Lastly, your QRS should be normal, narrow. However, you do have to remember that aberrancy can occur, and that does make things a bit more complicated, and you have to be on the watch for it. But by and large, true junctional rhythm has a perfectly normal looking QRS, which actually makes it very, very difficult. We'll start with the usual as we take a look at junctional rhythm. I have 1, 2, 3 beats on the screen, so we know it's slow already, right? So 3 times 10 gives us 30. If you look, it is a little bit irregular. 1 and 2 look further apart than 2 and 3. That is actually common when you are really slow. Slower heart rates do get a bit more irregularity in them. Ultimately, we're looking for any patterns or how much alike each of those beats are and if they can be compared to one another. We will say that there's really no pattern that we know of. And there's no ectopic beats that we're truly aware of. We have some weird things here and here that we may need to take a look at, but we'll come back to those in a bit. If you want to go through and truly measure these out, I will tell you right now, beat 1 and beat 2 are 61 small boxes, and beat 2 and beat 3 are 52 small boxes. And to work those out, just to give you an idea, doesn't matter how you cut it, that's a slow heart rhythm, period. Bradycardic. So let's take a look at our P waves, shall we? In hunting, there's nothing beforehand. All 3 of these beats are completely missing P waves in front of them. So no P wave. And that's where we'd normally expect to find them, correct? Well, we need to be extra sure, and so we're going to look after the QRS as well to see if there's anything that looks like a P wave there. And I am not really seeing anything that looks much like an inverted P wave, like a true kind of upside down scalloped type thing. So we're going to say after. Doesn't have anything. So if there is a P wave, it is likely hidden. And the QRS. So we have no P's per QRS. Well, if there's no P's, equals no QRS. So speaking of QRSs, what do we have? Well, the QRSs are uniform. They have a QRS pattern. And I'm going to go ahead and measure these out. We'll say this one starts about right here and ends about right here. 1, 2.5. So 2.5. 0.10, which is normal. So ultimately, we have a bradycardic rhythm with a normal QRS and no P waves. That is the definition of junctional escape. Apologies for that long pause, a bit of technical difficulty. So let's continue on with our accelerated junctional. This is a 6-second strip. We're going to go ahead and mark these out. And 8 times 10. We are regular. We have no pattern. We have no ectopics. Now, because we're regular, we can go ahead and measure these. I'm going to go ahead and measure from S wave to S wave because that's actually really convenient. And I come up with 20. Heart rate is 75. So that is perfectly normal. Let's take a look at our P waves. Do I have any P waves in front of my QRSs? And the answer is no P wave before. Well, since we're talking about junctionals, obviously you're going to say, well, it must be during it, and I can just move on. Well, it's really important to take that extra time to see if you can find those P waves after the QRS, because if you can, that just helps demonstrate how correct you are. So if we take a look at these, there's something that really awesome that happens is your T wave morphology is what's most likely to change. And if you look at number 1, how the T wave looks there, and then compare it directly to beat number 5, you'll see a drastic difference. And essentially, that's the inverted P wave after the QRS. The way this works is their energies are canceling each other out. The T wave wants to travel in an upward direction, right? Whereas that P wave is inverted. And so adding those two together creates a bit of a push and pull. So think about it this way, that you've got a T wave that slopes up and it kind of comes down like that. And then I'll draw a P wave that's inverted that goes something like this. And so then when you put those two together, you get something like that, where the T wave has that negative deflection of the P wave pushing it down. And so if you now look at beat number 6, beat number 5, in fact, beats 3, 4, 5, 6, and 7 all display this pattern of an inverted P after the QRS. Which is really cool. And so having one P wave per every QRS is hard to demonstrate, but in this case we've at least found a few of them. Now, because I don't have it in front, I cannot measure a PRI. I'm going to say and hidden as well, just to make note of it. As for the QRS, they are uniform. We have the R prime S pattern, and that's consistent across there. As for my width, we'll measure this one here actually, because that S wave ends on a solid line and we started right here. That's 3 small boxes. And so that is normal as well. So that leaves us with, we have a normal rate, inverted P's, and I have normal QRS. Oh, and we're regular, I forgot to mention that. That is accelerated junctional. Now you may ask the question, how did I get the R prime S pattern? Well, this is probably another great example of aberrant conduction in the case of junctional rhythms, and that's very, very common. Originating there right next to the bundle branches themselves, it makes it very possible for that to be conducted in a unique pattern, creating this type of stuff. So I would add that in. Of course, try and get a previous EKG on this patient or anything so that you might be able to compare it to see, did they have a bundle branch block or something beforehand? The fact that we came in at a normal 0.12 tells me that it's more likely to be aberrant than it is to be a bundle branch situation. All right, junctional tachycardia. Well, we'll start how we always do. This is a 6-second strip. So 11 beats total. We are regular. We don't have any ectopy or patterns. Now, because it's regular, I can actually measure from beat to beat to try and figure out what's going on. Conveniently, beat number 3, the QRS starts on a solid line, and this one ends right around here. And that gives me 13 beats or 13 small boxes. And that gives me a rate of 115. And so we are tachycardic. So let's take a look at our P waves. And we do have P waves, they just happen to be inverted, and they're in front of every single QRS. So we have So yeah, that's exactly what we want to see in any type of rhythm, is that it's regular, but more importantly that these inverted P waves are happening pretty darn consistently, and they all look quite a bit alike, honestly. So now let's go through and figure out what the QRS may be. So, or sorry, not the QRS, the PRI. Got ahead of myself a little bit. So we'll start with beat number 5. Let's see what we can find here. This one stops right here. I'll say it starts probably about right here or so. It's a little difficult to tell. That's 2.5. Let's try another one just to be sure. Next one over starts about right there. Ends about right there. 1, 2.5. Let's do one more to be safe. When they're inverted like this, it's always a little bit difficult to tell. All right, and so we have so we have a short PRI, which is one of the key things for junctional rhythms, correct? Is that you have a PRI less than 0.12. Finally, the QRSs are uniform. They're definitely identical, and I will say that they have the tiniest of QR patterns. And so now we just need to get these measured out. This may be a little bit tricky. you'll notice how the QRS slopes out a little bit towards the end. So it does make it a bit challenging sometimes, but we'll just go ahead and go with the ones that looked the cleanest. And so this one here, beat number 10, it's pretty clean, and we'll say that that's, gosh, between 1.5 and 2. We'll just call it 2. And if we look at some other ones here that might be a little easier to read, this one's right here. Yeah, right between 1.5 and 2. We'll round up. It really doesn't matter in this case. And that's normal. It's narrow, complex. That's more of what we're looking for. Is it narrow or wide? This is definitely narrow, kind of no matter how you dice it. So at that point, we have a fast rhythm that is regular, inverted P wave, short QRS, a short PRI, and a normal QRS. That is junctional tach. Just like that. So why is junctional escape important? Why is it worth all this time to try and figure out what it is and why it's going on? It's important to keep in mind that the escape part implies exactly what it is. It's a fail-safe mechanism. It's there to keep the organism alive as long as possible. So in the case of failure of the SA node, it makes an awesome thing. But some of the weirder things with athletes, the ones that are like Olympians, like really highly trained, they can get their resting heart rate low, actually below 30 in a lot of cases. Well, 30 is slower than that AV junction, and so sometimes they may actually be in a junctional rhythm more often than a sinus rhythm because they're so darn healthy. So kind of keep that in mind. If you have a fit patient, it may not actually be abnormal for them. The other significance I want to mention is follows up with that fail-safe mechanism. It's not uncommon to hear a story about a patient who comes in for a pre-surgical workup and they find out when they do the EKG that they're in a junctional rhythm, and that patient says, well, no, they're too young to have had a heart attack or anything, and they ask them more questions and they say, well, when I was in grade school and high school, they always said I had a really slow heart rate, but I never felt bad, so it was never really a problem. This may be a person who had a congenital illness or a congenital malformation that meant their sinus node never worked. And it was this junctional escape that kept them alive into adulthood. So it's actually kind of neat that it does serve a purpose. We just don't see it all that often. The clinical picture, though, they're just going to have a slow pulse. It's only a problem if you start seeing those signs and symptoms of cardiac output. So drop in blood pressure, things of that nature. They start looking symptomatic, loss of consciousness. And it's only going to happen really if it's an acute change. And so speaking of acute changes, what kind of triggers? Well, myocarditis, heart attack, open heart surgery, that really gets the heart ticked off. And good old digoxin poisoning, because that causes troubles for everything sometimes. On the flip side, with accelerated junctional and junctional tachycardia, those are usually more likely due to an irritable junction, meaning something's making that AV node, AV junction misbehave. And so should a patient come in with this, but that wasn't their normal baseline underlying rhythm, you have to assume that something's making that part of their heart upset. And so that's why digging deeper into these different causes is most valuable. Now, thankfully, accelerated junctional is your normal rate of 60 to 100, So they're not very often are they symptomatic. It just represents an underlying pathology, like why is this happening? Now, junctional tachycardia, because this can get up into the 180s, you might see some symptoms, but that's related to the extreme tachycardia and not as much to the rhythm itself. Either way, need to investigate why they're in a junctional rhythm for sure. Your patient started the shift in rhythm A, later alarm sound, and you see rhythm B. What action would be most appropriate? So we've started our shift in, well, we'll have to look. They start off with a tachycardic, and now they're Brady. Severe. Their heart rate of like 30. So this is a significant drop in heart rate. That alone tells you how big of a change this is and how panicked you might be. First off, we'll ask, does this look like it's a false alarm? No. Is it non-emergent and that the CNA can evaluate the patient? Again, I would say no. At this point, who needs to go look at this patient? Do we call an RRT and have the ICU nurse take a look at them? Or do we just notify the primary nurse and have them take a look? Well, this is not non-emergent. That's a very, very, very low heart rate. I honestly would recommend probably calling the RRT at that point and having the ICU staff be the ones that go take a look, because that right there might lead to something much worse. If you chose to contact the primary nurse first and then wait to see what they did, that could cause some delays that would potentially harm the patient in the long term. So I would say for a change like this from extreme tachy to extreme bradycardia, this is emergent, call an RRT and have the experts get in there. Okay, so a broad classification for SVT is narrow complex or narrow QRS tachycardia. You'll see this a lot in the literature. It's how ACLS describes things, so that if you just look at a monitor, all you have to say in your brain is, this is narrow complex, it's tachycardia, let's do it. It makes things much more reactionary, which is why it's being used. That being said, it actually encompasses a whole variety of actual rhythms, and that's what I wanted to demonstrate for you here, is just how many different things can truly be qualified as an SVT, or narrow complex tachycardia. Now, these are mostly based off of which parts of the heart are responsible. Ultimately, the most simple one, so if we'll start in the atria, you've got sinus tachycardia, atrial tachycardia. Those can go pretty fast. AFib, aflutter, multifocal tach. We've gone through all of these already, and you can see how if they go fast enough, you'd lose the P wave, and you just have to call it SVT. What's really fun is this also includes reentrant rhythms, and a reentrant rhythm or circuit can lead to SVT by creating a looping pattern, essentially is what happens. And you have a couple different types. So you have SA node reentrant, tachycardia, or you have intraatrial both of these being, so if you had sinus node reentrant tachy, that's what this one is here, where that sinus node has a feedback loop on itself. Or you could have this one here, which would be your ATAC or your aflutter, where there's not an anatomic obstacle, but it just keeps feeding in on itself. And so that would be your intraatrial reentrant tach. All well and good, all super cool. I'm actually going to change colors here for you. Now, with your AV junction, however, you can have another set. One of them is junctionals, which we've already talked about just a little bit. And you can see how junctional tachycardia, because it's due to an irritable focus, could create a bit of a loop within itself right here and feed on it. Or you can have, so AV node, reentrant, tachy, or you could just have AV, or reentrant tachycardia. All of these are for like the electrophysiologist to use to decide when to zap or what part to take out when they do ablations and things of that nature. But here's a really good one, the bundle of Kent. That's what's responsible for Wolff-Parkinson-White syndrome that you usually see in kids. But that's essentially where it goes through the ventricle, and then it takes this to loop back around, and it creates a pathway there. And you can see that there's lots of different ways that that can happen. This is just to illustrate how much variety there is out there, so that when you say SVT, it really is the most broad interpretation you can make of a rhythm. Now, the thing that I would add to these rules with your advanced arrhythmia is that your QRS might actually be wider, because you have aberrant conduction. Is far more common with faster rhythms. We talked about that a little bit with the AFibs, how you're more likely to see it. So it's no wonder that a heart rate that's running up in the 200s, it's very, very common. In fact, sometimes when a person's in SVT, it's nothing but an aberrant looking conduction, and then when it slows back down, it goes back to normal. And we'll go through a few examples of that as we move forward. All right, looks pretty ugly, doesn't it? I will just go ahead and open up with this and say, check the patient. Now, actually, in reality, this is a patient I was taking care of. I was actually standing at the bedside when this rhythm occurred, so I knew what was going on, but if I wasn't at the bedside, sure as heck this would get my attention, and I'd go scurrying in there to try and figure out what's going on. And I'll talk more about this history, this patient's history, but first, let's go ahead and pick this one apart, shall we? So we'll switch colors to green here, and we'll number them off. Now, this is a 6-second strip. And while you're looking at this, you can tell that it's pretty regular. There's no ectopic beats. They all pretty much look the same. They look pretty ugly, actually. All right. So rated 200. Very tacky. And no ectopy. Now, the undulates, I bet you're wondering why I said that, but if you'll notice that this entire thing kind of goes up and down like this, that is the patient's respiratory pattern. They were tachypnic, which is why you had basically a breath every 3 seconds. They were not having a good day. But ultimately, that's what explains that undulation up and down. Since it is regular, let's go ahead and try and figure out the rate. And so we'll measure between 7 and 8 because that one is on a nice solid line. And number 8 is right about here. And that is 7. And so if we do, that gives us 214. And if you measure that a little bit wider, because there's 1 or 2 of these that are like that, if you divide that by 8, you get 187. Either way, that's a nice fast strip. Now, can you see any P waves in this? Well, first let's look at this a little closer and see if we can't pick apart what we're looking at. And so we'll start here on the end with the 16, 17, 18. Right up here, this is your R wave. This is your S wave. This right here is your, that right there, sorry, is your J point. And this is your T wave and P wave combined. And you have R, S, it's your J, and then this is your T and P, R, S, TP. Okay, that hopefully gives you an idea of what we're looking at across here. And now that we know that no matter where we look, I'm just going to put marks above them, you really never see a good P wave anywhere. Someone could make the argument about maybe some inverted P waves after the QRS, and I think that's a perfectly reasonable discussion to have. And when the heart rate's this fast, without a 12-lead EKG, a true one to tell, you just can't. Either way, super fast. So we've got that, and that. Those are all there. For now, I'm going to say there's no discernible P waves. And so for that reason, we have no PRI, which then brings us to our QRS, and how the heck we're going to measure that. So I pointed out the J points earlier because that's what we're going to use to mark these out. So I'm going to start right here in the middle. Beat number 9 is a pretty good one. And so beat number 9, the QRS starts about right here. And then your J point ends about right here, just barely on the other side. 1, 2, 3. And so if we look over here again, any of these other ones here, number 7's a pretty good one because that starts on a solid dot. And this J point again ends right about here. 3. So we have uniform. They have an RS pattern. And we have 3 times 0.04 equals 0.12, which is actually normal. So for that reason, we have very fast, we have regular, no P waves, and we have normal QRS. SVT is going to be the best answer that we can give in this scenario, simply because we don't have more information. Now, for you advanced arrhythmia folks, I'm going to change to blue here so you can tell the difference. This is still kind of where we stand. You know, it's still SVT no matter how you cut it. What I do want to point out is, why is that QRS so wide? Why does it look so funky? And so I'll give you a little bit more information. This patient was already had a fast heart rate in like the 130s. They're a COPD, or they were on BiPAP. And in fact, they were actually in multifocal atrial tachycardia, is why their heart rate was so high. And they took their BiPAP off for about 15 seconds, and so we were readjusting it, trying to get it on, and they just shot up real fast into this exact rhythm while we were standing at the bedside. Got the mask back on, and in about 10 seconds, they came out of this and went back down to their slower MAT. So I know for a fact that this is MAT. However, the QRS changes occurred, and he was normally a narrow complex QRS, but when he kicked into this rhythm, it suddenly became wider and almost looked like VTAC initially. So what I would say for certain is that you could say that he was in MAT before, he's in MAT again, but without knowing that history, all you're left with is what you see. But we do need to make the addition because you do have that very wide QRS. And in fact, if you look a little closer, you could maybe make some arguments that there's a second R wave in there potentially. And I'll leave it at that for now, but just kind of look through this again from that advanced standpoint and say, what we're looking at and why this would be an aberrant versus just a standard SVT. That'll be more important as we go forward. All right, final bit to wrap up this section. Looking at this right off the bat, I'm sure a handful of you just feel like, oh, that's got to be V-tach. That's that. Well, actually, it's pretty common that SVT and V-tach can be argued against one another, because SVT can look that way in some cases, and that's my whole point. We're going to walk through that today. Ultimately, regardless of if this is SVT or plain old V-tach, you need to check your patient and follow ACLS, because that's what really matters here. Regardless of the rhythm, is the patient hemodynamically compromised, anything along that nature. So that's all there. Let's go ahead and number these real quick like. And yes, you can fast forward through this part. Looking at it, it's pretty regular, but I will say this. This is not a 6-second long strip. It's actually only just a little bit less than that. This is the 3-second mark. And what we can do is a little bit of quick math and say 11 times 20, because we're using a strip half as long, gives us a rate of 220. Now, looking across the strip, we will say that it is regular, that there's no pattern, and there's no ectopy. You can question number 8 because the QRS does look a little bit different. We'll come back to that, and I'm going to try and help explain why. But because it is regular, we can actually measure from beat to beat. So I'll measure between 9 and 10. That gives us 7. So we have 1,500 divided by 7, which is 214. So we are very tacky. P waves. Well, to find the P waves, you really need to be able to catch everything else that's going on. So we'll use these beats here at the end, 14, 15, 16. And I'm going to label everything out just to help everyone. This is R, S. That little mark there is our J point. And then this is the T wave. And if there's a P wave, it's hiding in there, because you come right back to the R, S, J. This is the T and P again. So on and so forth. So it makes it really tough to say what's one or the other. And ultimately, I'm going to say there's no P waves. However, if you look closer, there is some evidence of P waves that do poke their head through. And that's going to be this one here, this spot here, a little bit there. You could maybe argue that one, and probably again either here or here. So there are a few instances where, and actually you might even be able to say here, since that T wave looks a little flattened compared to the others, there's evidence that something could be going on in the background, but because of how fast this rhythm is and how large the QRS complexes are, without slowing them down or doing something different, there's no way to confirm or not. All that we can say is that there is some notching of the T waves, and leave it at that. And given this as the case, we cannot do a PRI. The QRSs are essentially uniform. And some of the reason why beat number 8 may look weird or different is because there is that P wave at the very start. Our pattern overall is a tiny R wave, a large S wave. In some cases, like this one here, beat number 11, definitely beat number 8, 4. It happens often enough. There is a small S prime that occurs before it moves on into the T wave. What's more important is that the T wave is opposite the QRS, so we do have to keep that in mind. Ultimately, if we measure this out, I'm going to go ahead and use beat number 13 for this. And just draw a line up here. And then from my J point up to right here. And that is 1, 2, 3. Right thereabouts. We can measure another one just to try and confirm. This one's pretty good. In fact, that one's 2.5. So if we do 2.5 equals normal. So we actually have a normal width QRS despite how large it may look. And I think one of the bigger tricks is that your isoelectric line is right across here. And so that you're dealing with quite a bit of ST depression, which makes it look a lot further down or a lot wider than it actually is. So that is something to keep in mind. Ultimately, we're very fast. We're very fast, regular, and uniform. We're going to go ahead and call that SVT. How do you explain the RS configuration, or the fact that it's a little bit on the wider side? Well, you can, and I think it would be perfectly appropriate to add in SVT with aberrant conduction. SVT with aberrant conduction, simply because it is wide, and when SVT does encounter aberrant conduction, it creates this pattern that is so similar to VTach. Ultimately, it's really cool when you can catch this and you can identify it, but treat them with ACLS. If they have a pulse, great. Use your tachycardia pathway. If they don't have a pulse, just go ahead and shock them as if it was VTach and you're trying to get them out of it. And go from there. All right, so that is it for the junctional rhythms. Narrow QRS tachycardia is another name for SVT, supraventricular tachycardia. This group of rhythms includes which of the following from this list, and so we'll just go through them. Atrial fibrillation, especially when you do RVR, absolutely can be part of the narrow QRS tachycardia groups. Atrial flutter, also, especially when you get like a 2-to-1 block and then it's going really fast, right? Sinus rhythm, I'm going to say no, simply because sinus rhythm is sinus rhythm. Now, a sinus tach absolutely could be part of SVT group if it's going fast enough. Junctional tach, definitely, because it's going fast enough, again, that it can look a lot like SVT for sure. And then ventricular tachycardia, no, because the definition of that is that it has a wide QRS, and so that is why that one is off the list. So, atrial fibrillation, atrial flutter, and junctional tachycardia. Your patient started the shift with rhythm A, later alarms sound, and you see rhythm B. What action would be most appropriate? Well, you first have to figure out what rhythm A is, and then what's going on with rhythm B to decide if it's emergent or non-emergent. So rhythm A really does look like junctional tach. You got that upside down P wave, and our heart rate's somewhere in the 151, probably in that 120s range. So we're definitely moving along at a pretty good clip. Rhythm B is that same junctional tach, but then we have a significant change here at the end. Now that looks like V-tach at first, but it may also be supraventricular tachycardia. Regardless of which of those it is, I think it's SVT. But that increased heart rate, because now we're looking at something that's closer to 160 to 170 beats a minute, and at that point we really need to change what we're doing for the patient. I would automatically say that we're not dealing with something that's non-emergent or false, that a CNA could go look at. Now in terms of being non-emergent versus emergent, we need to notify that primary nurse, absolutely. Do we need to call an RRT at this point? Not necessarily. That may be a bit of a judgment call, but I would strongly recommend that we contact that primary nurse immediately and escalate if unable to contact them in short order, at which point maybe the RRT is your next best choice. So emergently, contact primary nurse as quickly as you can and escalate. You see the following rhythm alarm on the monitor. What actions would be most appropriate? Well, this is longer than 6 seconds long, but you can see that through here we had a definite something go on. And thankfully the patient came out of it and went back to their normal rhythm. And so the question becomes, how emergent is this? Well, what do we know for sure? It's not a false alarm. Something like this happens, it's not appropriate for a CNA to do anything with. Do we need to call an RRT for this type of a patient? No, because it was self-limited. It canceled itself out, which leaves you with, is it non-emergent and we'll just eventually let the nurse know? Or is it more emergent that we're going to contact that primary nurse as quickly as we can and escalate if we can't get a hold of them? And that's where I kind of lay, is that this one here, we need to really get a hold of that primary nurse immediately, because these things tend to happen in groups, and so they might have another one in short order. And you want that primary nurse to get in there and evaluate them as soon as possible. To treat this as non-emergent, I think would be inappropriate. So, contact primary nurse immediately. When providing care to patients in supraventricular tachycardia, SVT, which of the following are priorities for your care? Just look at this list and it's what you would do for any patient, right? If your patient's in SVT, you need to visualize them. You have to go lay eyes. While you're there, you definitely need to check a pulse, collect those vital signs. If there's no pulse, what are you going to do? You're going to initiate CPR. However, you need to confirm if they're DNR, DNI status before you go off and do that kind of stuff. Obviously, if there's no way of knowing, err on the side of a good Samaritan and start intervening accordingly. But if you're able to check for a purple wristband or know what their wishes are, follow them. Are you going to ambulate a patient to the restroom who's in SVT, especially if it's new onset? Absolutely not. There's no ambulation. Keep them in bed. Check level of consciousness, of course, but that's again part of your visualization of the patient. It's part of talking to them and working with them. Now, if your patient is on the floor, are you going to move them to the bed immediately? The answer is no. You're actually going to take care of the patient right where they're at, make sure there's enough help in the room, then maybe you can move them if it's appropriate at that time. But if they fall into the floor, just keep the scene safe. So of this list, I would say it's the ambulate and the move the patient, that those are not your priorities.